Hello, doctors. Today we are going to study about the topic acute and chronic pelvic inflammatory disease, or we can call this as PID. It's a very important topic because it is one of the most common causes of pelvic pain and tubo-ovarian abscess and infertility in young women. And so here in this today's session, we'll focus on the clinical presentation of PID and the investigations what we have to do in this condition, and as well as the OPD versus the IPD management. So moving on to the introduction. So PID, it is basically an inflammatory disease, or we can tell like an infection and inflammation of the upper female genital tract, which that means uterus, tubes, ovaries and the surrounding peritoneum. So we classify this into two, like acute and chronic. Acute when it presents suddenly with pain, fever, tenderness, and and so this is the thing in acute. And as chronic, when it leads to some scarring or adhesions or infertility, that we can call this a chronic. So we have to keep in mind that the early recognition of this disease is very important during for managing the condition in future. So it includes endometritis, salpingitis, tubo-ovarian abscess, and pelvic peritonitis, and classified into two acute and chronic forms. So this is the basic introduction of what is PID. Moving on to the etiology. So what causes PID? So most often it starts with the sexually transmitted infections. So most common like STIs like chlamydia, trachomatis, and gonorrhea, Neisseria gonorrhea. So these are the most common thing. And later the flora becomes mixed with the anaerobes and enteric organisms joining in. So other organisms like mycoplasma, anaerobes, enteric bacteria. And what are the risk factors here? Risk factors when there are multiple sexual partners, unprotected intercourse, adolescence, prior PID, and recent instrumentation like IUCD, insertion, and abortion or hysteroscopy. So when you take a history of the patient, also like during this condition, you have to always ask about the risk factors. So these risk factors should be asked to the patient while taking the history of the patient. Next comes to the pathophysiology of PID. So pathophysiology of PID, the infection usually ascends from the cervix upwards. So first there will be acute inflammation which leads to some pus, edema and all, and even tubo-ovarian abscess. Then if it is not treated well, when in the acute stage only, if it is not, because in acute stage there will be active infection. So when you are not treating it properly in the active like acute stage, if it is not treated well, it heals by fibrosis which can lead to adhesions, hydrosalpinx and blocked tubes. So that's the and once if you are not treating it properly, it can lead to the chronic form, that is it can lead to fibrosis, adhesions, hydrosalpinx and infertility. So that means the mechanism so that is the mechanism behind the infertility and ectopic pregnancy after PID. So there are many cases where the young women are diagnosed with PID, and after PID diagnosed there are chances of infertility and ectopic pregnancies. So that's why when we are deciding any treatment for PID, it should be early and aggressive. So the treatment, diagnosing the condition is very important in PID, and the early recognition of the condition and the early treatment, even in the acute stage itself we have to treat it properly, otherwise there can lead to chronic stage. So that is the pathophysiology of PID. Next is the clinical features. So first we'll discuss about the clinical features in acute PID. So in acute PID, the classical picture here is lower abdomen pain, maybe like this will be often bilateral pain, fever and abnormal vaginal discharge, a purulent discharge. So these are the three things we have to keep in mind when talking about the acute PID, one, the patient experience a lower abdominal pain or pelvic tenderness, often bilateral pain, and there will be fever and abnormal discharge. So these are the three important thing. And next other are there can be dyspareunia, dysuria and all. And on examination you will feel that cervical motion tenderness, we will say chandelier sign, so that will be present in the acute PID case. So as I mentioned, so women will also have this dyspareunia or dysuria things. So but remember, sometimes the symptoms are mild and you still find significant disease on ultrasound, so maintain a high index of suspicion. So this is what talking about the clinical features of acute PID. So acute PID cases, you have to keep in mind the three important points, that lower abdominal pain, fever and abnormal discharge, and there can be is dysuria and dyspareunia, and there will be a chandelier sign, that is cervical motion tenderness on examination. So this is the acute PID. Moving on to the chronic PID. So what are the changes in chronic PID? As I have mentioned in the previous slides, once if you are not treating the condition in acute stage, that is when there is active infection, that thing can lead to a chronic stage, second stage, chronic stage. So it can lead to chronic PID. So in chronic PID, what happens here is the patient may complain of persistent pelvic pain, that is chronic pelvic pain, and pain during intercourse, and there will be menstrual irregularities or infertility and ectopic pregnancy risk, or difficulty in conceiving. So that is the main important things where when you will see in chronic PID, the patient explain of chronic pelvic pain, menstrual irregularities and infertility. So difficulty in infertility or otherwise ectopic pregnancy risk. So and as you have seeing in the acute stage, there will be dyspareunia as well in the chronic PID also. So the underlying problem here is scarring and adhesions, not acute pus. So always think of PID as a cause of infertility alongside endometriosis and tubal fractures. So this is the thing about the chronic PID. Next comes to the so I hope you got a idea of what is acute PID and what are the features you'll be seeing in the patient who's having acute PID, and what are the clinical features you are seeing in the patient who's having chronic PID. Next is the investigation. So what are the what do we do in terms of investigations in this PID condition? First is urine pregnancy test to rule out any ectopic pregnancy. Also always do this test before further moving on to the another investigation. So first thing is urine pregnancy test to rule out any ectopic pregnancy and all. Next you can go for CBC and ESR. So ESR will be raised in this condition, CRP for inflammation. And next thing you can do is NAAT testing, cervical or vaginal swab for STI testing can be done. So we are doing this for, like as I've mentioned, it is mainly because of the common any STIs. So testing for chlamydia and gonorrhea is required. So you can do a NAAT thing, and this one, cervical vaginal swabs, and you can go for ultrasound pelvis to look for any tubo ovarian abscess or hydrosalpinx. And if this diagnosis is in doubt, you can go for a laparoscopy. So laparoscopy is a gold standard for diagnosis. So investigation, first thing you have to do the urine pregnancy test and make sure it is like that it is not positive and like so that will help you to rule out the ectopic pregnancy. So first thing you have to do that, then go for lab test, then imaging test and the clinical suspicions. So that will lead to the diagnosis of the condition. So this is the most important thing, investigations you have to do in this PID. Moving on to the management principles. So what are the principles of management? So coming to the management, the first rule here is don't wait for any reports. So if you clinically suspect PID, start the treatment. Second rule is decide whether it is OPD basis or versus the IPD depending on the severity of the case. Third, always cover the gonococcus or chlamydia or anaerobes with your antibiotics. And finally, treat the patient and also treat the partner, and ask the patient to abstain from the intercourse until both partners are treated and symptoms resolved. So maybe because there are chances of like STI, sexual transmitted infection. So always when you are advising treatment, you have to advise for both the partners. Treat both the partners and ask the patient and the partner to abstain from the intercourse. So once both the partners are treated and symptoms are resolved, they can continue. So sexual partner evaluation is also important, and treatment for both the partners also important. So then now we have to know how we can say like how we can manage the condition OPD basis and as well as the IPD basis. First comes the OPD management. So in OPD, only the most cases will be mild to moderate cases without any abscess or systemic toxicity. So these cases can be actually most of the cases can be handled in the OPD, because in initial stages, when the patient is in the acute stage itself, they may come for the treatment. So we can even only if you are not treating it properly in the acute stage, it will lead to a chronic stage and maybe it requires an IPD management. So OPD management, most of the cases can be handled in this OPD. You can start an empirical antibiotics for 14 days. Ceftriaxone 500 mg IM single dose or 1 gram if the patient is less than 150 kg. Doxycycline 100 mg twice daily for 14 days. Metronidazole 500 mg twice daily for 14 days. And tell the patient to complete the full 2 weeks of the treatment or medicines. Don't take Advise the patient to not take alcohol with metronidazole, and protect the skin from sun if the patient is on doxycycline. So skin can be skin sensitivity during the sun exposure. So protect the skin. You have to advise them to protect the skin from sun if on the doxycycline medications, and also ask them to come back in 48 to 72 hours for reassessment. So these are the things, and you can advise NSAIDs for pain relief, and also advise them rest, hydration, and abstain from the intercourse. So these are the things you have to advise them in the OPD management. You can advise these tablets or medications also. And if there is no improvement, like if the patient symptoms is not subsiding with these treatments and medication, then you can escalate to the IPD management. So this is what in the OPD basis. Moving on to the IPD management. So IPD management, who all requires an IPD basis management, who needs an admission. So in indications of IPD management, when the patient is suffering from severe illness with fever, the patient is pregnancy, and if there is tubo ovarian abscess, or if the patient is not able to take oral medications. So like if you are managing in the OPD cases, if the tablet if the symptoms are not subsiding, or if the patient is not getting relief from the tablets, when you give an OPD basis, that can like OPD failure. So if it is not properly managed by the OPD, then you can advise to in the IPD basis. So these are the things where you can admit the patient and treat the condition in the IPD basis. So in the hospitals, we can give IV antibiotics 42 to 72 hours. Then we can switch to the oral. Example, ceftriaxone 1 gram IV daily plus doxycycline 100 mg IV or PO twice daily, with metronidazole 500 mg IV or PO twice daily. So this is the one of the example. Uh, Next, we have to monitor the vitals, urine output, and then markers also. So once the patient, if once she improves after 48 to 72 hours, we can switch to the oral to complete the 14 days. So if there is a large or ruptured abscess, then image guided drainage or laparoscopy is needed. So drain abscess is required if there is any large or ruptured abscess. So supportive care is IV fluids and analgesic. So this is the way you can treat the condition in the IPD basis. So I hope you got a idea of how to manage in OPD versus IPD management. Moving on to the complications and follow up. So complications include, like as I've mentioned in the previous slide, infertility. There will be chronic pelvic pain, ectopic pregnancy, risk of ectopic pregnancy are the complication. And next is tubo ovarian abscess rupture. It can lead to peritonitis, sepsis and all. Then there can be recurrent PID and adhesions also. So that's why follow-up is very critical. So counsel the patient about the future fertility, and if the patient doesn't want to conceive after a year, she may need a fertility workup. So this is the thing about the complications and the follow-up you have to do to the patient. Moving on to the prevention and takeaways of today's lecture. So to finish, prevention is the important key here. Promote safe sexual practices and uses of o- contraceptive pills or condom uses. So to avoid any STIs, and screen high risk women for chlamydia and gonorrhea, and treat the partners as well when during the when treating the patient. You have to always treat the partners, and delay the IUCD insertion if cervicitis is present. So if there is cervicitis in the patient, don't do delay the IUCD insertion. And next important thing is suspect PID if there is pelvic pain with cervical motion tenderness. That is the key point here. So if the patient complains of pelvic pain and on examination you felt a cervical motion tenderness, then you can suspect a PID. Start empirical therapy right away and decide whether you have to treat the patient in OPD or IPD. And OPD versus IPD should be based on the severity of the case. And always remember, like early treatment prevents the long term infertility. So you have to early diagnose the condition, and early recognition is very important. And then next thing is you have to be quick enough to treat the condition. So don't wait for report, as I've mentioned before. Don't wait for reports. If you are clinically suspecting the condition, if you are okay, correct, thorough with the clinical symptoms and all, then you can go directly to treatment. If there is any doubts or anything, you can go for the other possible investigations which I have mentioned in the slides. So this is what about the PID. And always as I've mentioned, always treat if the patient is having a condition like acute PID. Always try to resolve the condition and treat the acute stages, treat the patient acute stage itself, not leading to chronic stage, because it can lead to infertility and other ectopic pregnancy and other risk and all. So prompt treatment of acute PID or to prevent the chronic PID. So that's it about today's lecture regarding the acute and chronic pelvic inflammatory disorder. It is one of the most common cases we will see in OPD basis. So thank you so much for today's session. I hope you got a clear idea and better clarity of today's discussion. Thank you so much and have a nice day.